in all situations, at all times, and amid all people. Thank you, Dhruv. Over to you, Dhruv.
Thank you very much, Dr. Rajkumar. Now I request our President, Dr. Rajendran sir, to say a few words and start the program.
Thank you, Thuru, and most respected our President elect Central IAP, Dr. Singarwell sir, and President 2024, Dr. Balashankar, and so Dr. Somasundaram, President 2026, and Secretary Dr. Narmada, President Dr. Rajkumar, Coordinator and President elect 2000, Thirumurugan. And so, on behalf of IAP TNSA, I welcome one and all. This is for this event. I sincerely appreciate our convener, Dr. Ahmed, who is for designed focused academic sessions, and I thank our expert, our and as well as resource faculties, Dr. Tabisha Kumar, Dharlakshmi, and Dr. Raju sir from Tannaveli, and Dr. Venkata Subramaniam from Sivagasi, for graciously sharing their expertise. And so it is really, yes, you know that infectious disease continues to challenge us with, we are going for epidemiology and as well as growing antimicrobial resistance also, and vaccine preventable threats also going up. And more than that, the parents are more so anxious about that what's outgoing everything. And as a pediatric practitioner, we have to give clear-cut clarity and as well as confidence and updated knowledge. So if we are giving that only, we can go for save the lives. So this aspect, I think it's really, we are having a Tamil Nadu infectious disease chapter. They're doing wonderful activity under leadership of Dr. Dr. Aswath Spas. And I think that followed by that chairperson elect Dr. Dhanlakshmi also. And it's definitely this program today, infectious disease related topic, and it's a wonderful faculties are here. Definitely will give a clarity regarding our current infectious disease, what's going on. And thank you very much. So please, Thuru, you can proceed.
Okay, so thank you very much. Now I request our President-elect National IAP 2026, Dr. Professor Singarvelu sir, to say a few words and start.
Thank you, Dr. Thiru. First of all, big thanks to all our members who joined, who supported our mission for electing me and giving a credential to our Tamil Nadu with our respected President, Dr. Rajendran, and the past IAP presidents, and my dear colleagues of IAP and the guest speaker, Madam Tapisha ma'am from Delhi, and our own person, Dr. Raju, Dhalakshmi ma'am, and Venkata Subramanian sir, Satish sir, and our my wishes to Jalil sir. Today is birthday. Happy birthday, Jalil sir, Vishwanathan, Shivaprasam, and all those who joined and giving a very good support to all our academic program, which was going very nicely, which gave a very good input to all over India that Tamil Nadu is doing extremely well in academics. That is a very important aspect for success in our election also. So I should thank our president and his visions for making this happen. And surely our Aswath is doing a great work in his P4 program. So hats off to Aswath. So with this, without wasting much time, once again, thank you for giving me this wonderful opportunity as a scientific coordinator of this year, where we could do a lot of program which not only influence Tamil Nadu, all over India, even abroad also, many people who visited. Thanks to Thiru and all for your efforts. Wish you all the best. Thank you for giving me this opportunity once again. Thank you.
Thank you very much, sir. Now, I don't know if there is anybody else to be called upon. Dr. Gopal, is he here today? If he's not there, then
Dr. Narmada இருக்காங்கன்னா
Then I'll request our Dr. Ashwath to start the program without any further delay. Thank you very much, Dr. Ashwath. He has been doing a fantastic job of assembling the best possible faculty, and we are into the 10th edition of our program, except for last month when, because of the elections, we couldn't handle it. And each and every one of them absolute hit, and has been very useful for our practitioners. So over to Dr. Ashwath for another very exciting and entertaining session of P4 today.
Thank you, one and all. I think IAP TNSC's dynamism and the efforts taken by Dr. Nataraja, Dr. KR and Thiru and Dr. Shingarvelu in putting Tamil Nadu on the India map is something fantastic. They say, no, Ipade Thorkin, Ipade Vellumari. Like Chanakya, Dr. K. Rajendran, ably assisted by his team, who really worked so hard to put Dr. Shingarvelu back in the hem where he belongs. It is a great source of pride for IAP TNSC, as well as single-minded devotion and focused energy over the past so many months. They worked to get the Tamil Nadu the credit that it deserves. So I'm once again thankful to IAP TNSC for bestowing faith and having me to conduct this P4 series. I'm also thankful that we were able to get this week because 18th to 24th, as you're all aware, is the WHO-sponsored World Antimicrobial Resistance Awareness Week. So as part of the Tamil Nadu PIDA state chapters wing, we wanted to make sure that we have some topic related to infectious disease discussed in this week, which starts on 18th and ends tomorrow, 24th. So it is with that respect that we wanted to have a good CME on a topic of interest. And we are delighted to have Dr. Tapisha Kumar from Delhi. She heads the pediatric infectious disease at Max Specialty Hospital. She's also been the president of Delhi IAP East Zone. She'll be aided ably by our own little superstar, Dhanlakshmi ma'am, who needs no introduction. She's admittedly, madam said it's very difficult for me to give one-line answers. Even in the MCQ exam, she is known for writing essay answers. Her knowledge is so vast. So I'm sure from both of these two giants, we are going to learn a lot more and fine-tune our practice. Her co-panelists will be Dr. Raju from Tirunelveli, who's put Tirunelveli on the pediatric academics map and who's been for the past 40 years single-handedly running the show at Krishna Medical Center at Tirunelveli, where is a medical director. And Sir has also contributed papers in various journals. His topic of interest has been Kawasaki and HLH. And he is going to bring his practical wisdom and 40 years of distilled pediatric practice to share with us. And the last panelist will be Dr. Venkat Subramaniam, who is an unsung hero soldiering on at Anai Medical Center at Sivakasi for the past so many years. He is an alumnus of the Madras Madurai Medical College. He has also been associated with the Tirunelveli Medical College and a very keen member of IAP Virudhunagar branch, Madurai branch, and also Sivakasi. These are all multifaceted personalities with years of distilled wisdom. So over the next 1.5 hours, we hope to have very meaningful deliberations on burning topics. So with that brief introduction, I will invite Dr. Dhanlakshmi ma'am to first start a presentation on office-based approach to influenza-like illness. That will be followed by another brief lecture by Dr. Tapisha from Delhi on interesting snippets from her case files, followed by a free-ranging discussion on pediatric infectious diseases topics. Over to you, ma'am. Thanks once again, IPTNSC, for having faith in us. We hope we have lived up to your expectations. Thank you once again.
Thank you, sir, for a nice introduction. Good evening, dear all. So happy to interact with you all. I'm just sharing the session. Able to see the screen, sir? Hello?
Yes,
madam.
Yes, we can see the screen.
Yes, sir. Good evening, dear all. So as sir rightly pointed out, we are celebrating the World AMR Awareness Week, 18th to 24th November. So, and main theme of this year's celebration is protect our present and secure our future. So we all used to think that this AMR happens only in the hospital setting, but a lot of times now the AMR is happening in the community acquired illnesses also. So unless we act now, there will be no drug left over for us to treat the resistant infections. So since this is a season of viral infections we are seeing, so we will see how to differentiate viral versus bacterial illness. So how to differentiate? So most of the time we label as influenza-like illness. So what do you mean by influenza-like illness, and how to categorize this, and when to start treatment for influenza, and what are the indications for antibiotics in this upper respiratory infections, and something about pharyngotonsillitis. So we see a case scenario here. We have a 1.5-year-old child with fever of 2 days duration. Tmax is 101. Interfebrile period, child is active with occasional vomiting, no other localizing symptom. Elder sibling also had fever for 3 days duration and recovered well. On examination, child is hemodynamically stable. Systemic examination with the normal limits. So what would be the likely diagnosis? How to differentiate viral versus bacterial illness? Any role of CBC and CRP in differentiating viral and bacterial illness? So with this clinical scenario, so first thing is we like to differentiate viral versus bacterial. So how to differentiate? So viral illness usually will have a high fever at onset, and it usually gets settled by day 3, day 4. And sometimes we see biphasic pattern. Typical example is dengue fever. And in between fever, the children will be usually non-toxic and they'll be playing well. And if there is a multi-system involvement, again, it gives a clue. And if more than one family member is affected, and epidemiology, these are some of the clues for viral illnesses. On the other hand, bacterial illness usually starts with low to moderate grade fever, peaks by day 3 or day 4, and they will be usually toxic. And interfebrile period also some lethargy or decreased activity may be there. And usually bacterial illness will localize to one system, and there may not be any sick contact in the family. So this is how we differentiate viral versus bacterial. And if you look at this case scenario, this child had a family history. The sibling had a recent similar illness, and epidemiologically, an interfebrile period child is normal, so looks more of viral illness. And what about the role of CBC, CRP? Either only, if you look at without the clinical condition, CBC alone does not have adequate sensitivity and specificity. There is no substitute for history, physical examination, good judgment. So by day 2, day 3, I think stable children like this, there is no need to order for an investigation. So what about CRP? So CRP usually rises after 4 to 6 hours and peaks by around 36 to 50 hours, and levels decreases rapidly with the resolution of inflammation. But a single CRP is neither sensitive nor specific enough to identify all children with serious bacterial infection. Usually a very high CRP does suggest a bacterial infection. What do you mean by very high CRP? Usually if you take cutoff of more than 6 is positive, if it is more than 9 to 6 only, it can suggest there could be a possibility of bacterial infection. There are other non-infective causes also, like we can discuss later. So with this clinical presentation, with the possible diagnosis of viral illness, what is the treatment we are going to prescribe? Either amoxicillin, amoxiclav, oseltamivir, supportive measures. So here, viral illness, obviously, we are going to give only supportive treatment. Any role of oseltamivir? So most of the time we see what is happening is in a busy OPD, we will write probable viral illness, but the children 101, 102 fever, if the mother keeps on asking questions, we tend to write antibiotics. So that's why we always insist make a diagnosis first. If you write viral illness, obviously we will avoid writing antibiotics. So with the diagnosis of probable viral illness, we are going to just give supportive measures. So whether there is a role of oseltamivir, so there are 3 categories as per Ministry of Health and Family Welfare, category A, B, C. Category A is when only mild symptoms, ILI, like typical, whatever we have seen in this child, influenza-like illness, minimal symptom. Here, there is no need for testing, no need for any specific treatment also. Category B is severe symptom and high risk group. So we'll see what is high risk group. Here, if you feel child is sick enough, then you can consider treatment. There is no need for testing. Category C is severe symptoms. Child needs hospitalization or in ICU. So severe symptoms, here we need to test and treat. So antiviral treatment is usually recommended for hospitalized children, severe, complicated or progressive illness, or at risk for complications. So who are children at risk for complication? Any comorbidity, underlying any respiratory illnesses, any chronic respiratory illnesses, or any cardiovascular illnesses, children with immunosuppression, pregnant women, and in the immediate postpartum period, and children who are on aspirin therapy, and obese children. These are some of the children who are prone to develop severe influenza. So oseltamivir only in category B and category C, not in category A. It covers both A and B. And what are the benefits of in oseltamivir? It can shorten the duration of illness. It can reduce the risk of complication. and mortality benefit. So even though most of the guidelines, CDC, WHO recommends giving oseltamivir for severe illness, the evidence is very small. So although the oseltamivir has been demonstrated her excellent safety profile, there is a controversy regarding the efficacy of oseltamivir in children. So the most important reason is there are no studies in children. There are only few, if you look at the case reports, only small group of children are studied. There is no RCT, randomized controlled trials, which was conducted in children. And this neuraminidase inhibitor treatment was associated with reduced mortality in adult patients, but the mortality benefit has not been shown in pediatric patients. And there are lack of significant therapeutic effect on prevention of complications like pneumonia, sinusitis. We write oseltamivir thinking that it might reduce complications like sinusitis, bronchitis, pneumonia, but there is no proven effect on that. And again, effect against influenza B is doubtful. So oseltamivir treatment does not significantly reduce the duration of fever, nor does it relieve influenza-like symptoms in children with probable influenza. So the efficacy of oseltamivir in influenza is very minimal. So with this category A, child was given only supportive measures, reassured, warning signs explained. But on day 4, he becomes irritable. Fever spikes are persisting, no distress and no hypoxia. What is happening? You look for complications. So on examination, the typical finding of acute otitis media. So otitis media, we know less than 6 months. If it is a severe disease, we are going to give antibiotics, unilateral or bilateral, non-severe disease also. Less than 6 months, all categories need treatment. 6 months to 2 years, severe symptoms we are going to treat. And if it is a bilateral disease, we are going to treat. Unilateral, non-severe symptoms, we can adapt a wait and watch policy. More than 2 years, only for severe symptoms, we are going to treat. Either unilateral or bilateral non-severe symptoms, we can wait and watch. So this child has 1.5 years old child with severe symptoms, day 4 fever persisting. So we can plan to write antibiotics. So what treatment is advised? It is either amoxicillin, amoxiclav, or cefixime, or azithromycin. So always when you think of bacterial illness, think about what is the organism responsible. So if you take AOM, the organisms responsible are Streptococcus pneumoniae, non-typable Haemophilus influenza, Moraxella catarrhalis. And the commonest thing is pneumococcus. So we are going to target pneumococcus. We know non-meningeal isolates of pneumococcus, the penicillin resistance is very less. Even the recent ICMR data in 2023 suggests it is less than 2%. So the drug of choice here is amoxicillin. So what are the, when we prescribe upfront only amoxicillin, there is no antibiotic exposure in the last 30 days. And if the child does not have purulent conjunctivitis, if the child has purulent conjunctivitis, then it gives a clue for Haemophilus influenza. In that scenario, we can add clavulanic acid. Otherwise, in stable children like this, only amoxicillin, standard dose amoxicillin, that is 40 to 50 milligram per kg per day for minimum duration of 10 days. So what is, when you prescribe amoxiclav, if there is a recent exposure in the last 30 days, the child has received antibiotics in the last 30 days, and there is a concomitant purulent conjunctivitis, which suggests it could be a Haemophilus influenza, and child has not responded to amoxicillin after 48 hours, then this scenario we consider adding amoxiclav. Usually amoxiclav for respiratory illnesses, it is prescribed in the dose of 7:1 ratio. So what is new in the treatment of AOM? Usually we give 10-day treatment, but for uncomplicated, more than 2 years old, we can give 5 to 7 days. This is a recent recommendation. So moving on to the next case, we have a 3-year-old child with fever of 5 days duration, and fever is moderate grade, fever up to 103 degree. Started initially with the running nose, which is now thicker, whitish discharge. Cough has never been his predominant symptom. On examination, child is febrile, toxic with purulent discharge. So what could be the diagnosis? So this is a ABRS. So what are the 3 presentations of ABRS? It could be a severe symptoms like in this child, high-grade fever for 3 to 4 days with purulent rhinorrhea, and we have no obvious other focus. Or it could be a persistent symptom, nasal congestion, rhinorrhea, or cough more than 10 days without improvement in the symptoms. Like daytime cough is essential to make the diagnosis of ABRS, or it is a double worsening. The child recovers from a viral illness kind of thing, 3 to 4 days, fever, cough, cold, then well for a few days. Again, there is a recurrent symptoms, return of symptoms after initial resolution. So these are the three presentations where we consider ABRS as our diagnosis. So if it is ABRS, how we are going to manage either amoxicillin, amoxiclav, cefpodoxin. So here the same organisms which causes AOM is going to cause ABRS. Again, Streptococcus pneumoniae, non-typable Haemophilus influenza, and Moraxella. So the first line is still amoxicillin 40 to 50 milligram per kg. Second line is amoxiclav. Azithromycin is no longer recommended because of high degree of resistance. Again, duration of treatment is 10 days or 7 days after the resolution of symptoms. So last case, we have a 6-year-old child with 2 days of fever, sore throat, no cough. There is on examination, we find unilateral tender cervical adenopathy. This is a throat examination picture. We see erythematous beefy tonsil and uvula with palatal petechiae. So how to differentiate whether it is a viral or a bacterial? So usually bacterial age group between 5 to 15 years and with a significant tonsillar inflammation, and palatal petechiae gives a clue for bacterial, and lymphadenopathy will be tender and unilateral. If there is a scar lentiform rash, again it gives a clue for bacterial. On the other hand, any other system involvement like conjunctivitis, cough, coryza, GI involvement, diarrhea, or any oral ulcers, these are the clue for viral illnesses. But sometimes this is not like as in textbook description, we will not see some child. Clinically, there will be difficulty in differentiating viral versus bacterial. We can apply Mekizak score. So this is a score we commonly apply. If the temperature is more than 100.4, it carries 1 point. Absence of cough, because cough favors more of viral. So absence of cough carries 1 point. Tender unilateral cervical adenopathy, again 1 point. And if there is a significant exudate, 1 point. And age group, if it is 13 to 14, it's a common for group A beta hemolytic streptococcus. So it carries again 1. 15 to 44, 0. If more than 45, the bacterial is less likely, so -1. So if you apply the score, so how we are going to manage? If it is 0 or 1 score, there is no need for testing, no need for treatment. And if it is score is 4, if you don't have facility for treatment, for testing, then we can directly treat. And the score of 2 and 3, ideally, if it is possible, you test and treat. And here again, first line is amoxicillin. It is 50 milligram per kg per day, either once or twice daily, and maximum is 1 gram per day. And the duration is 10 days. And if there is allergy only, you consider other class. For example, it's a non-type 1 allergy, consider first generation cephalosporin like cefalexin, cefadroxil. Non-type 1 allergy, you can consider giving macrolide. Avoid amoxiclav, second and third generation cephalosporin. Here, group A beta hemolytic streptococcus has never developed resistance to penicillin. So adding clav is not going to help in pharyngitis. So take home messages, majority of the respiratory illnesses are viral. So differentiate viral versus bacterial infections clinically and always explain the warning signs. And category A ILI does not warrant oseltamivir. And if fever persists beyond 3 to 4 days, look for complications like sinusitis or ABRS. First line antibiotics in AOM and ABRS is still amoxicillin. And for pharyngitis, first line is still only amoxicillin. There is no role of amoxiclav, cefixim, cefpodoxim, or azithromycin. So avoid macrolides. So macrolides are indicated only if there is a strong suspicion of mycoplasma, or sometimes very rarely we tend to see pertussis, or when there is a penicillin allergy. These are the indications where azithromycin should be used. High degree of resistance is noted in pneumococcus and group A beta hemolytic streptococci. So therefore, it is inferior in community acquired pneumonia, AOM, ABRS, and pharyngitis. So the main reason for antibiotic resistance is overprescription of antibiotic or unfinished treatment. For example, if you are convinced it is group A beta hemolytic streptococci, we have to insist on completing the treatment. So this is one of the main reasons for the development of AMR. So unfinished treatment, overuse of antibiotic in the livestock, poor infection control practices in the hospital, and lack of new antibiotics being developed. They say in the last 30 years, there is no new class of antibiotic like beta-lactam, aminoglycosides. Whatever we are getting, the newer antibiotics are a modification of the existing antibiotics. So there is no new antibiotics being developed. So if you don't handle the AMR properly, we will end up in post-antibiotic era.
Thank you, ma'am, for those very nice illustrative cases and stressing the superiority of sticking to good old time-tested amoxicillin as the first drug of choice. Parent habits will be very difficult to change, but repeatedly listening to words of wisdom will probably make us rethink our prescription habits. Thank you so much, ma'am. Can I have the next speaker, Dr. Tapisha Kumar from Delhi? Ma'am
Sure,
is a
I'm
member
here.
of the
Yeah.
Urology Pediatric Infectious Disease Society. She's been past president of IAP. She's also authored multiple articles for textbooks, and she also has been part of the standard treatment guidelines group on infectious disease. Madam's pet topic is Salmonella typhi and its gory adventures. Over to you, ma'am.
Thanks a lot, Dr. Ashwath, and many thanks for the warm welcome, Dr. Rajendran and Dr. Singara Velu. It's my honor to be invited here. And I just want to say that I consider myself a student of infectious disease. I'm not an expert. Dr. Dhanalakshmi is expert, and all of you are experts. I'm here to learn from all of you. I'll start my presentation now. Hope everyone enjoys it. Yeah.
Perfect, ma'am.
So, yeah. So, coming straight to the first case, this was a 7-month-old male baby who came with fever for 4 days, high-grade fever up to 103.8. And on history, there was nothing else, no running nose, no cough, no loose stools. And he was brought to the hospital because he had become dull and he was not feeding well. When we did a detailed physical examination, we couldn't find any focus. So we had this thought that this is a male infant, high-grade fever. Probably this is UTI. So we sent all the routine tests and urine routine and also the cultures. Urine culture and paired blood cultures were sent. And after sending samples, we started ceftriaxone. Yeah. So the initial reports came and the TLC count was high neutrophilic, CRP was high 68. Urine routine showed 10 cells per millimeter cube. This was a catheterized sample. And since the counts were high and there was no localization, we also did an X-ray chest, which also turned out to be normal. Now the child is on ceftriaxone and high-grade fever continues over next 48 hours. We were not suspecting a CNS infection because the child was okay in between fever spikes, sensorium was normal, and AF was level. So we just wanted to take some history again, and history was revisited. And we came to know that this is a bottle-fed baby on formula. Parents are maintaining hygiene while preparing formula. They're educated. And there was a history of travel to South Asia about 10, 12 days back for a function. That is all that we could elicit. And by day 3, however, the fever is now up to 104.5. So are we thinking of UTI at this point? Because the fever spikes are actually increased a bit. Child is not looking that great. Should we now upgrade an antibiotic? Is this ESBL E. coli? Is it a resistant organism? Because by now, parents are very worried. Every spike of fever, they tell us and call us and say the fever is not getting better. And so the doctors become anxious too. Urine culture by 48 hours comes negative. So will we still think of it as UTI? No. But what saved the day? Blood culture grew Salmonella typhi. And most likely it was water that they had used. They had used tap water while they were traveling. So probably because of that, this happened, because otherwise on detailed history, water and everything was normal. So only ceftriaxone was continued. We did not need to add aminoglycosides or switch to a higher antibiotic, and baby was discharged on day 7. So the learning points we all already know, just a revision, that enteric fever can happen less than 1 year. We've seen in as young as 6 months. We always take good history, which helps a lot. Our country, unfortunately, because of poor wash, sanitation, hygiene, It has one of the highest disease burdens in the world. And there is absolutely no role of using fluoroquinolones because most of the strains are resistant while we are treating enteric fever. In children less than 2 years, this is very good data from Chennai, which tells us that 15% of total cases happen in children less than 2 years. We come to the second case. This was an older child, 15-year-old, who was having fever for the last 10 days, which was high grade, up to 103. Last 4 days, he started having some cough, went to a doctor on day 5 of fever. No tests were done, some antibiotic was started. As he did not get better, parents were worried, but 2 days back, he actually started having difficulty in speech. He was not able to speak very clearly. He had slurred speech. And he was also having an unstable gait. He was not able to walk. He would get up and then feel unbalanced, unstable, and sit down. That is why they brought the child to the emergency. There was no history of any headache in these last 10 days of waking up at morning because of severe headache or projectile vomiting, and there was no alteration of sensorium. On examining, the child's vitals were normal and general physical examination was fine. CNS examination just showed a slurred speech with wide-based ataxic gait and dystotocokinesia. On examination of the limbs, power was normal and all the deep tendon reflexes were elicited. And there were no focal deficits or cranial nerve involvement. There were no meningeal signs, and fundus was also normal. Rest of the examination was normal except for some hepatosplenomegaly. There was no history of any trauma in the last 1 week or any drug intake or history suggesting anything else. No recent viral illnesses. Yes, the father had pulmonary tuberculosis with hemoptysis a year ago and had taken treatment for that and had completed the treatment according to him. So can CNS tuberculosis present like this with ataxia? Yes, it can. We sent the initial tests. These were the tests not really pointing us in any direction, non-specific. X-ray chest was normal. There was no focus anywhere. We took a pediatric neurology consult who said that let's do an MRI first and then decide whether we want to do an LP after the MRI report. So we really didn't know what the cause of this ataxia is. Now the MRI head comes normal. And so our diagnosis of CNS tuberculosis goes down the dustbin and fever high grade continued. Luckily, we have a great microbiology lab. The culture flagged positive in 24 hours. We were informed it's gram-negative bacilli, and in 48 hours, we got a report of Salmonella typhi. This child was in good luck. So his fever, not only the fever settled, his neurologic symptoms also settled slowly over the next 6 to 7 days. So we really did not do an LP or anything else. We did not add any other medicines except ceftriaxone, which continued. We didn't need to add steroids, etc. And child was discharged on day 8. In follow-up, had recovered. His neurologic symptoms had all recovered. So we all know that these neuropsychiatric complications are well described, and they used to be described much earlier in olden times, but still they happen on and off. Cerebellar ataxia is a para-infectious condition, well reported in enteric and also in other virals, usually occurs in the 2nd week of fever. And we must understand that not every child with a history of contact will develop TB, to keep our eyes and ears open. And remember that sending good volume of blood culture in every child ideally before starting antibiotics will always bail you out in tough cases. This is another last case. So this was an under 5 child, 3-year-old. He was having fever for last 7 days. He had been shown to some doctor nearby. Some tests were done. He was started on oral medication. He came to the hospital because he suddenly developed severe pain abdomen. He came at around 12 o'clock in midnight. He was quite dull with some distension, tenderness at McBurney's point. But this history is not like acute appendicitis because he had fever first and pain abdomen started just a day ago. We did an emergency ultrasound, which was normal. And then he was started on antibiotics after sending all the investigations and paired cultures. But by next morning, within 6 hours or so, he had worsened. He had had a perforation. The pediatric surgery team was involved, taken into the OT, and appendicectomy as well as a peritoneal lavage was done. And of course, the blood culture grew salmonella in 48 hours. And this child had a very bad post-op course. He had to be intubated. He was there with us for almost 10, 14 days, etc., etc. So we must understand that, of course, disease can have varied manifestations. We keep reading about it and we still keep learning new things. We should also remember that typhoid dot can really mislead. There is definitely an association of appendicitis with enteric fever because the appendix also has Peyer's patches. But when such a thing happens, whether to operate or not is a decision that has to be individualized because the small intestine is quite friable in this disease. And we all know that we must have the culture of sending cultures because the maximum number of that beautiful blue dot in the center is the maximum number of cases in our country, almost 40% of global burden. And to add to the problem is the problem of ceftriaxone resistance. There is an ongoing XDR epidemic in Pakistan where almost 15,000 cases have been reported, resistant to all 3 first-line plus fluoroquinolones and cephalosporins. What is the ICMR latest data, 2023? So it shows that in our country, luckily, the ceftriaxone susceptibility is still to the tune of 96.8%. But following very closely is azithromycin susceptibility, which is not 99 or 100, but 97.4%. And see that the ciprofloxacin susceptibility is just about 2%. This is a recent data from CMC Vellore, where we were told that in 2023, they had 180 cases were reported to them from Gujarat, which was of XDR typhoid, which were resistant to all except carbapenems and azithromycin. And in 2024, which is even more scary, these 50 cases came from Pune, Bangalore, and Kerala, which were even resistant to carbapenem. All the more important to not use 2 drugs like both ceftriaxone and azithromycin, or not to treat empirically, but to treat based on the sensitivity patterns. Typhoid dot is very popular, quite a lot in North India. I'm not so sure about south of the Vindhyas, but it is an unreliable test with lack of standardization of kits. There are recent studies and meta-analysis published last year. One good one from Bengaluru, another from Ghana, which largely proves this, that you should not rely on this test. It's a serology test, which can have pitfalls anyway because of anamnestic reactions due to other infections. Individually, one may not mount an antibody response. Prior antibodies may persist due to subclinical infection. So there is a large possibility of being misguided by the results of this test. We know that blood culture yield depends on volume sent, the microbiology infrastructure, and prior use, but understand that sending anywhere between 1 to 3 ml or up to 5 ml is sufficient in pediatrics. In infants, we send around 1 ml of blood. In newborns, 0.5, of course, not for enteric. Between 1 to 5 years, we send 3 ml of blood, and after 5 years, we send about 4 ml of blood in the blood culture bottles. The pediatric blood culture bottles are have a broth of about 20 ml. So 4 ml is the maximum volume that can be sent in one bottle. And of course, microbiology infrastructure so that they have the BACT alert machines is quite important. And understand that this bug grows very beautifully. So we've had children who were on cefixime in enteric dose for 1 or 2 days, and yet they grew salmonella when we sent, because we always send a good volume. They were on multiple other antibiotics, but still they grew salmonella on blood culture from our lab. So it's an important test to send. We know that for prevention, single dose of the vaccine is recommended currently. There is some new data published in Lancet, which is a Bangladesh study, which says that if you give a single dose TCV early on, before 2 years of age, then there is a decline in protection 3 to 5 years later, with the greatest decline in those vaccinated at younger ages. So a booster dose at school entry may be needed to sustain the protection during the school years, when the risk is highest. I think once more and more data collects and the data percolates to WHO and perhaps later on to IAP, there may be a change in our guidelines in the coming years. And I just thank everyone from the bottom of my heart for having me here. Thank you. This is a Kural, by the way. I'm sure all of you know.
Ma'am, that was really touching. Like our PM, you have also made the ruler popular and you have respected a great son of our soil. We are really touched by that, Kural. We sincerely believe that each one of us carries it in our hearts rather than merely putting it as a slogan. Thank you so much for those beautiful case vignettes of how typhoid continues to tease us, cheat us, and continues to disguise itself in so many ways, ma'am. Ma'am, we'll let you get a couple of minutes of voice rest. Ma'am,
Yeah,
can
thank
we
you.
go back to Dr. Dhanlakshmi?
Yes,
Sure.
yes, yes.
Ma'am, some queries related to what you said, because you
Okay.
came down really hard on azithromycin and made him look like a villain. Whereas Dr. Tapisha has made that azithromycin sensitivity in typhoid is
That is
even
what
better
I
than that
wanted
of
to
Sefton.
preserve. See, for XDR
Correct,
typhoid,
ma'am.
we have only one drug available. So I think above the diaphragm, azithromycin was used to be prescribed above the diaphragm infection, but need to preserve for below the diaphragm. In fact, for now, we have so many cases of Shigella, which was resistant to ceftriaxone. In that scenario, also, we need to use only azithromycin. So preserve azithromycin for XDR typhoid and ceftriaxone resistant Shigella. So this should be carry home today.
Fine, ma'am. Ma'am, regarding this MACIS score, you have said
Yes, sir.
rapid antigen testing, throat swab culture, those are beyond the reach of most of us, ma'am. So my question
Yes.
to you very clearly is, in office practice, if I have a MACIS score of 2 and above, am I
Okay.
justified in writing a 10-day course of amoxicillin without any further testing, where facilities are not available?
2 and 3, it is difficult, sir. Actually, it is based on the clinical decision only. I think if it is 2, I may wait for 1 or 2 days, couple of days to see whether child is clinically improving. If it is 3 and 4, if you don't have facility, you can consider treatment. Actually,
Perfect.
RADT is a bedside test. In fact, SBSR he is doing in his clinic only. So you can order the kit and it takes about 5 to 7 minutes only. You can get the results immediately. So as sir always says, if there is a will, there is a way.
Correct. And Dr. Pramod Jog used to jokingly say, whenever you feel like writing an antibiotic, he'll say, go have a cup of tea and come back, that
Yeah,
interest will
then
pass off. So you will start, that rush will
definitely.
come. It's like an adrenaline rush. Thanks for that interesting observation, ma'am. Now, Raju, sir.
Okay.
Sir, if a small child, let's say a 2-month or a 3-month-old baby is brought to your clinic by panicking parents with high-grade fever, please can you run through important points in a busy OPD that you would want to ask in history and run through in physical before we decide whether the child is sick enough to warrant further investigations, or can we reassure them blindly and censor? 3-month-old infant, high-grade fever, without any focus on history. Dr. Raju's approach.
Good evening, everyone. 3 months itself is a high risk, So 3 months you have chances of big infections in mind. So just do not send the child thinking that it could be another viral infection, though you may have contacts at home. So you are justified in doing some investigations or screening the child at least before sending the child home. But in our practice, I think it is better to admit this child for observation before you are 100% sure that this is an ongoing infection and the child is otherwise all right, taking feeds and all, and the parents feel all right. Otherwise, a 3-month-old child with high-grade fever should be treated as an at-risk child, and it should be treated urgently.
What is the absolute basic minimum history taking and basic investigation that will suggest for all babies in this age group, sir?
So the 3 simple things which you can do anywhere is a complete blood count and probably in the OP practice CRP and a urine routine examination. And you should have a good dipstick to show leukocyte esterase plus nitrates, everything in one dip. And that should be the thing. And also the complete blood count should also show the absolute neutrophil count.
So you may have a high CRP, but if ANC is otherwise normal, I may not give much importance. But this may not apply to this 3 months old child, where you can have
So
even a lymphocytic response.
in a screaming irritable child, is there some point in history which will give us some clue about the probability of this, sir? Some not to miss points in history.
Yeah, not taking feeds, not looking at the mother, and the mother will see this child is not doing well. That is a good history.
So it's more of observation of appearance, breathing, consciousness. It's a
Definitely,
simple
it's
pediatric assessment triangle is more than
yeah,
enough, sir.
it is an office practice, so that kind of a good history is more important in screening the child whether to admit. But I would say personally, these children with high fever, 3 months old, should not be just sent home saying that it's an ongoing fever.
So, Dr. Venkat Subramaniam, in your practice, in a 3-month-old child without fever, what are the common causes of fever that you've come across, sir? Can you also share your inputs on what are the non-infectious conditions that can mimic a septic process, which we should not be misled by?
So in my office practice, thanks for the opportunity, Asudha, first of all. In my office practice, a 3 months old child is having a fever without any obvious focus. Most common diagnosis which I come across is UTI, complicated urinary tract infection. And next one is bacteremic sepsis. By doing blood culture, we are able to grow a lot of sometimes even many bacteria infections as well. And first of all, I will approach the case with any other family member who is having similar any febrile illness at home. Because of this viral season, the infant at the 2 months or 3 months old baby is brought with, and usually some other either elder child or some other family members is also having some viral like illness. Then it points towards the viral illness only.
Yes, sir. Are there anything in non-infectious conditions? Because sometimes we also tend to err on the side of infection, start broad spectrum antibiotics, pending reports. Do you come across any inflammatory conditions in such a young child which can mimic sepsis, and you've sort of learned subsequently that it's not an infection? Anything that we have to keep our minds open out for?
I never come across such a child in my practice as well.
Sure, sure. And Dr. Raju, sir, can you please comment about the practical difficulty in getting a urine sample for culture? Because it's guidelines say that you should get a clean catch. 3-month-old child is difficult. Back sample may be good enough for urine complete. Can you please comment about this so-called quick pee method or the reluctance on the parents to get a back sample done? How do you cope with such people in practice, sir?
Yes, you have almost like 60% contamination when you do a back sample, that we all know. So there is one simple thing called the Broomhall's method, which I learned when I was going through the literature 2 years back. This is just working on the antidromic reflexes by Truta's theory. That is, you stimulate the skin, reflexes go to the spinal cord, and then stimulates the torque, and then naturally the bladder will empty. So what you have to do is carry. This can apply only to children who can be carried on your hand. So take the child on the hand, and then give 3 taps just in the suprapubic region. Then turn the child upside down, and then give 3 massage over the sacral area. Repeat this 2 or 3 times, and then you can also scratch the perineal area, because you know it's an S2 S4 segment. You have the reflex arc working, and I find from the feedback from the parents, most of them could collect clean catch specimens, though not midstream.
Sure, sir. Now, if a parent is possibly refusing to have a invasive form like a suprapubic aspirate or a culture sample, how confident can we be in a back sample being a source of UTI? Can ultrasound help us to confirm or refute the possibility of acute pyelonephritis?
Yes. Here, I think when you're getting I told you almost like 60% of the back samples will be a contaminated thing. So if the child is otherwise sick, definitely go for an ultrasound. Many a times, even last month, we had a child with good acute left side acute pyelonephritis, and that responded to the parenteral antibodies. That can happen.
By properly explaining to the parents, somehow we can focus them for, and they will be accepting for catheterized samples.
Okay, thank you. Dana ma'am.
Yes, sir.
Dana ma'am.
Yes, sir. Yes, sir.
Very often in practice, we see this habit of practitioners underlying 15 to 20 pus without LSC or nitrate being positive, bacteria 1+ on a bag sample, urine complete or a autoanalyzer sample, getting labeled as UTI and started on Cefixime straight away.
Okay.
So what are the pitfalls of empirical antibiotics, or other words, what are the other conditions that can produce pus in the urine without it being a UTI?
Yeah. As such, fever itself can cause pyuria. So most of the times we see in Kawasaki sterile pyuria. So without urine culture positivity and LE nitrates being negative, the chance of this being UTI is very, very less likely. So look for other causes. Only pyuria, urine culture not growing organism, and LE nitrates negative, this is unlikely to be UTI. So fever could be the reason, or think of other causes, like sometimes renal stones, some underlying renal issues, anything can cause pyuria.
Ma'am, the other thing is the IAP guidelines, even the recent guidelines continue to keep saying ultrasound should be done for all children with UTI. That is the only investigation that is recommended.
Acute phase, sir.
No, understand. What I'm saying is the yield of ultrasound and picking up anything other than a duplex or kakut or something great is very, very low. So why are we continuing to rely on ultrasound whose sensitivity for picking up a UTI or a cause for UTI is so low, ma'am? It's not going to pick up
Actually,
a VUR.
ultrasound should be ordered not to diagnose UTI, only to look for underlying structural anomalies only. So the recent IAP guidelines, it goes 15 to 20% of children with UTI can have underlying congenital anomaly. So that is the reason. Usually, if we give antibiotic and the clinical response you achieve in 48 to 72 hours, we will not do ultrasound during the acute phase. Once the inflammation settles down, after 3 to 4 weeks, then you get a baseline ultrasound. Then based on the ultrasound, we decide on further investigations, not during the acute phase. Suppose if fever is not settling after 2 to 3 days, then local complications like any pyonephrosis and any other things we are missing, then we order ultrasound during acute phase. But generally, nowadays we are moving away from doing ultrasound during acute phase.
Ma'am, for the benefit of the audience, can you please tell us what are the current indications for doing an MCUG after first febrile UTI, ma'am? Who needs an MCUG, and what is the rationale for not doing MCUG based on age group? That was the old guideline. What made them change their mind and make it more restricted testing?
Actually, now we are moving away from doing more invasive procedures, and there is no point in picking up the low grade VUR, like grade 1, grade 2. Even if you pick or not pick, it's not going to affect the management in total. So that's why upfront we are not doing MCUG for all cases. Generally, for recurrent UTI, we are doing MCUG. So recurrent UTI is second episode of UTI, provided it should be culture proven. So if it is a recurrent UTI, or if the ultrasound is abnormal, so if you get a dilated ureter, dilated upper ureter, lower ureter, or pelvic ileal system dilated, so significant findings in the ultrasound, then we may consider doing MCUG, or the guideline recommend non-E. coli UTA first episode, you can consider MCUG. So these are the indications where you upfront order for MCUG, but it's not like previously, all UTA should undergo MCUG.
Perfect, ma'am. Right. So recurrent UTA, atypical pathogen, younger child, or a grossly abnormal ultrasound should be the only reasons why we should go for an invasive testing. No point picking up low-grade reflex. Thanks, ma'am.
Yes,
Madam, even for male children, we wait for the second UTA?
Yes, sir. We can wait. Sir. Antenatal ultrasounds are normal. See, the Western guidelines are moving literally away from MCUG. They have a good antenatal ultrasound. In fact, even if you have a 6-month-old infant with UTI, if antenatal ultrasounds is normal, they say you can wait for subsequent episodes. We are not going to pick up any major abnormality. So that is the reason. So if you have a good antenatal ultrasound, in fact, you can wait.
Dr. Ashwath, can I make a few comments regarding?
Definitely, ma'am. Please do, ma'am.
Yeah, so there are few things that when we are diagnosing UTI or having initial suspicion, a lab picture of urine routine is is quite good in the lab. In the clinic, a dipstick, as Sir said. With the dipstick, one has to be careful that if the dipsticks are not kept properly, the nitrite will come positive. If the dipsticks are exposed to air, nitrites can come as false positive. That's one thing. With the lab sample, if the sample, there is a delay in sending it to the lab, again, the nitrites can be false positive because of bacterial growth, because E. coli grows so fast. Nitrites can also be false negative in a urine routine, which has multiple pus cells, because nitrites, for nitrate to convert to nitrite, the urine should be in the bladder for 3 to 4 hours. And usually small children may not have that because they empty urine frequently. So you could have a urine routine which has multiple pus cells and nitrites negative. Then as far as the bag sample is concerned, bag samples, of course, are very good for urine routine. There's no harm. Of course, they have good negative predictive value for ruling out UTI. As far as the clean catch versus catheterization, suprapubic is almost out. I don't think any one of us really does it.
Right.
And in children who are admitted for UTI, who are unwell, sick looking, I think we can straight away go and catheterize. In OPD, of course, we have to counsel the parents. Understand that in clean catch, even if you are collecting the sample for routine and it's dribbling a bit and you collect that, it is okay for routine, though not at all okay for culture. That's also important. Just these small points I wanted to.
Ma'am, while on the subject of sampling, you came strongly as an advocate for blood culture because in each of those occasions, the blood culture picked up the Salmonella typhi for us. So please tell us, when would you order a blood culture in the first child, in the first place? Under what conditions will you ask blood culture? Are there any easy to remember rules as to the volume of blood to the broth volume, ma'am? Assuming that we are using pediatric blood culture bottles.
Yes. So when to order blood culture is whenever I'm talking about a child not 3 months old. I'm talking about say 2 to 5 years old. Beyond 3 days of illness, if the child seems to be bacteremic, and not without focus, that is when you have to order a blood culture. In IPD patients, you should send paired blood cultures. In OPD, you could send a single blood culture. And now most of the tier 2 cities, tier 3 cities have very good microbiology backup. We should not think that it's an expensive test and let's not order and start an antibiotic, because as you saw in all the 3 cases, a lot of headache was taken away because of the culture report and we could practice good antibiotic practices. So as a general rule, although IDSA guidelines and other guidelines speak about large volumes of culture, practically what many big ID experts do in the country, or what we do in our hospital is, as I repeated, in an infant we send 1 ml, 1 year to 5 years we send 3 ml, and above 5 years we send 4 ml of blood. And that amount is sufficient for at least for Salmonella and Staph, these we grow very well. In fact, if we have a child in whom we are suspecting enteric based on the initial reports or on clinical history, if the child doesn't come, if the blood culture doesn't come positive for Salmonella, we actively look for something else. Because if you send this volume of blood, Salmonella will grow really well, whether it is the first week or second week, it will grow really well. So what we hear about 90% in this week, 70% in that week, you can think that on one hand, but on the other hand, if you're sending a good volume of blood, Salmonella will grow beautifully. That's all I wanted to say. Anything you want to add, Dr. Dhanlakshmi?
No, ma'am.
The broth,
Before starting antibiotic,
Yeah.
as far as possible, better to take culture and then start.
Yes. So
Yeah,
blood to broth ratio should
should be
not
1:5.
exceed 1:5. Should not
1:5.
exceed 1:5. So that is why 4 ml is the maximum we should use, because the old, the Bactec Ped blood bottle has 20 ml broth. Now there is a newer one also available in some centers, which is the Bactec Ped Plus bottle, which has 30 ml of broth. So in that we can maybe send a higher volume of blood, but for all practical purposes, 4 ml maximum makes good sense, because if the blood broth ratio gets disturbed, then the bacteria will not grow.
Dr. Venkat,
Yes.
so you have an 8-year-old child with fever, relative bradycardia, has already been exposed to cefixime, not settling down. Counts are showing leukopenia, eosinopenia. You are picking up a mild splenomegaly. The child is febrile, toxic. Enteric fever is very strong on your differentials, but the baby's fever is now more than 8 days old. So in your practice, and madam has come down very heavily on serological tests for typhoid. Vidal is no longer being talked about. Vidal, MON2, these are probably things we will only write short notes about and probably not use in practice. So how do you, in your practice, pick up a diagnosis of typhoid? How often do you actually do bone marrow culture? Do you ever use stool culture? I mean, how do you manage? How do you confirm typhoid in your practice, sir?
Yes, yes. Actually, like many of you, I also have the habit of not starting antibiotic before taking blood for culture. So if the baby is not sick and if the clinical suspicion is enteric fever and the baby is not in the inpatient scenario, I will go for cefixime with 20 milligram per kg per dose. Or if the baby is sick and not taking food and it is very dull looking, the baby is naturally admitted and I will go for injection ceftriaxone. The enteric fever dosage. And usually in my clinical practice, when all the typhoid fever, most of the typhoid fever case, enteric fever cases, they are not taking enough food and they will usually get admitted. So it is easy for me to go for IV antibiotics. And if the elder child not admitted and on cefixime, if it is not getting settled down, then I will admit the baby and go consider whether if the culture is not taken, then I will consider going for alternate azithromycin 20 milligram per kg per dose, considering as a drug-resistant typhoid fever. Or if the child is sick, then the child will be admitted and I will go for meropenem.
Sure, sir. Dr. Raju, sir, your take on the same clinical problem. Clinical impression, Dr. Raju feels the child has got typhoid, but parents are refusing an invasive test like a blood culture. Are we justified in treating on clinical grounds, or would you insist on a microbiological diagnosis, sir?
No, I think you have to do a microbiological diagnosis, and should be a standing instruction for those children getting admitted with a diagnosis of FUO to have a blood culture done before starting antibiotics. And there are few practical hints that if you had not instructed your staff or your juniors properly and antibiotics had been given, and you can collect specimen before giving the next dose of antibiotics, because morning you get ceftriaxone, if 12 hours or 16 hours over, you can collect the sample. And theoretically, you have a chemical called SPAS, sodium phenyl amino something. So it's called the SPAS, which you can add, and then I think it takes away the antibiotic effect from the blood, and it can have a good yield of the bacteria. But of late, we have not been, because I had been practicing for nearly 45 years now. And of late, taking blood culture before starting antibiotics has become a habit, and we are strictly adhering to that. And we have a back tech, good to say, and we are getting good yield, especially paratyphoid. We get good yield.
That's right. Raju, sir, you said apart from a clinical examination, you would rely on basically three tests: CBC, a CRP, and urine complete. Now, CRP we know can go up even after immunization, vigorous physical activity, IM injection, virtually everything. So at what power, at what value of CRP would you actually consider it to basis to start an antibiotic or suspect bacterial infection? Is there a cutoff value that you use in practice?
Yeah,
Or any CRP more than 20 milligram per liter, you are going to be wary of it?
So, as I said first, we do CBC and CRP, or not CRP alone. So we believe mostly in CBC as going with Painiraman. And in that CBC, if you have a good CBC reader, you have few things like not only total count, polymorphs, not only polymorphs, don't believe in this polymorphs. Many times I have found polymorphs should be 90%, but when you see the absolute neutrophil count, it will be less than normal. So I would say a single pointer would be an absolute neutrophil count, which would tell you it's an acute bacterial infection, more than CRP. As Dhanam Madam said, it should be 16 times of the normal from the lab to say it should be a significant CRP. But even in the past week, in the prevailing viral infections, we have found CRPs of 120, 130 with absolute lymphocytes count more we are seeing. So any value of CRP, unless we are sure about the diagnosis, is not a good indicator of a bacterial infection.
Yes, especially influenza and adenovirus notorious for causing CRP elevation. Yes. Thank you. Dhanlakshmi ma'am, in this viral fever season, when doctor hopping is also so common, we have given paracetamol where child's fever is just not settling down with paracetamol. Parents are insisting on something more powerful. They believe that rectal or parental paracetamol is the way forward. Are there any studies to show the superiority of anal suppositories or paracetamol by needle or even intravenous paracetamol being superior, ma'am? What is the rationale behind sticking to oral paracetamol? That's first question. Second, Dr. Tapisha, once ma'am has finished, you could answer. Why are we so paranoid about not giving alternatives like nimesulide, mefenamic acid, or ibupara combination? They are all extremely popular and widely used, ma'am. Why should a general pediatrician desist from using such combinations?
Yes, sir.
Dana, ma'am?
Yes, sir. Studies have clearly shown actually rectal paracetamol is inferior to oral paracetamol. It's an erratic absorption. So obviously in unconscious children only, maybe sometimes children will be brought with febrile seizure. So you will not be able to give. In that scenario, you can consider. Otherwise, for normal children, rectal suppositories are not advisable. And the IV also, post-operative pain, when you are in NPO status or unconscious children, they say 1 dose of IV paracetamol. The main thing is we need to counsel the parents. Fever is not a disease by itself. It is a symptom of underlying disease process. So there is no point in bringing down the temperature to normal. As long as the children are comfortable, you should not be too much worried about fever. So I think needs counseling. And now we are seeing a lot of dengue with a low platelet count, hepatic dysfunction. We are worried about giving other than paracetamol, even brufen also. We avoid giving during this season. So again and again, counseling will help.
In children with the profuse vomiting, 1 or 2 doses of rectal paracetamol can be given as an emergency measure.
And what dose would you recommend, Dr. Venkat Subramanian? Is it the same 10 mg to 15 mg or slightly more, because it's available in only certain strengths, no?
Yes. I go for 15 milligram per kg per dose, as 6th hourly as well, sir.
Paracetamol by rectal route?
Paracetamol by rectal route, because being practitioners, we find two things as she commented. Paracetamol by rectal route, I do not know how it works, but the moment you insert a bullet inside, the parents are all right, child is all right. I do not know. That is you may have a lot of RCTs, but this is a clear-cut thing which we are saying. And the other thing is, lot of people in the periphery, they use IV paracetamol. You may give a lot of paracetamol and counseling. And then I asked one practitioner, you give IV paracetamol for all babies. He asked me, suppose it is your grandchild, what will you do? You want the fever to come down immediately, no? So in those cases, it is good. Definitely, yes.
Yeah.
Tapisha, ma'am, your take on non-paracetamol drugs for bringing down fever, do's and don'ts.
Yes. So just two comments on per rectal paracetamol and IV paracetamol. So per rectal paracetamol, the problem is that whether it achieves the bioavailability is not as good as oral. Of course, for IV it is 100%, but for rectal, the exact bioavailability is not known. That's one important thing I wanted to say. IV paracetamol is risky to give. So definitely in pediatric ICUs where children are not able to take their own respiratory support or some such thing, you can give. But generally in periphery, if the child is able to take, there can be problems with adverse effects because it's a 10 milligram per ml solution. So exactly loading it correctly and that you need to give it slow, or whether you're giving it in the IV drip and giving the whole drip, all these things can cause problems. So one should avoid them. As far as mefenamic acid and nimesulide is concerned, there is absolutely no pediatric data. So in case something happens, you will be caught, because parents are quite smart these days. They'll do a Google search and say, why did you write this? So they should not be used. The drugs that are the antipyretics that are advised by the various bodies in the world, one is of course paracetamol, the other is AAP also recommends using ibuprofen. And remember that no paracetamol less than 3 months and no ibuprofen less than 6 months. Now, this is what the AAP recommends. But as far as my practice is concerned, we have seen that paracetamol is the safest drug to use, and
Even a
it
newborn.
works well. And the end point of fever management, this is what we have to tell the parents in the OPD, that the end point of managing or tackling that fever is the child's comfort and hydration. So if we tell them that you give a dose of paracetamol and the temperature comes down to 100 and the child starts playing and is also drinking water and passing urine, do not worry about getting it down to 98 or 97. This is exactly what we have to tell them. Even in the hospital wards, when we have had dengue seasons, when children are also getting fever up to 104, 105, we have used oral paracetamol and tepid sponging, and that has worked. So very important to understand this. Do understand that sometimes in our OPDs, we may have to, satisfy the parents ki, oh, this is not happening, what to do. When pushed to the limits, because
Ma'am's audio is frozen.
ibuprofen, there is enough safety superior to mefenamic acid and nimesulide. We should not use that. Yeah. So, can you hear me?
Yes, ma'am. Yes, ma'am.
Yeah.
There was a brief
So,
period when you were not
yeah. So
reaching us.
mefenamic acid and nimesulide, definitely a strict no-no. Paracetamol is the best. If at any point of time we feel that we need ibuprofen, should also be safe. But remember, the problem with ibuprofen is renal damage, and understand that children who are getting high fevers also have higher insensible water loss. So they may be dehydrated. So if you're giving a lot of ibuprofen to a dehydrated child, or you're giving ibuprofen in the dengue endemic zone, can you hear me?
Yes, ma'am. Yes,
Yeah.
ma'am.
If you're giving it in dengue season or dengue endemic zone, it will alter the platelet function and then you will be in trouble. So paracetamol, paracetamol, and paracetamol is what we all have to remember. That's my take on it. Just counsel the parents that don't get the temperature down to 97. 100 is also fine if the child starts playing and is drinking water. I tell them that the disease, the body is fighting the virus. So don't worry if it's 100.
Correct, ma'am. Calming, assurance, counseling, hydration, comfort. I think if those 3 C's are taken care of, how many degrees of C in that thermometer, I think parents' temperature will also come down. Dana, ma'am?
Also, every time we need to check with the parents what strength of paracetamol they are having.
Yes,
sometimes younger children may be prescribed 120, older children may be getting 250. So out of anxiety, they will be misplacing the dose. So every time it is double the dose. And again, as far as possible, try to avoid using paracetamol drops. So always prescribe one formulation. And if it is 250, 500, tend to use tablets. Tablets, always they have the habit of checking the strength, but syrup, they always misunderstood.
Yes.
And drops also, it is in the liquid form. So most of the parents will think syrup and drops are the same. So we need to ask whether it is in a filler form or in like you are giving in a cup. So make sure we are giving the correct strength of paracetamol. Every monthly, one child with paracetamol toxicity due to the liver failure we are seeing in the ICU. So,
absolutely right. Even though it is the safest drug, it is the drug which has maximum medication errors, dosing errors happen with that drug. It's the commonest drug to have dosing errors.
Even in drops, we have 1 ml is 100 mg, 1 ml is 150. I think there are some regulatory issues. So even brand switching becomes extremely important to avoid. They should stick to one brand.
And 100.4 should be the target temperature.
Yeah.
38 degrees or 100.4. That is enough.
Yeah.
At that temperature, I think no child will develop a febrile seizure.
Ma'am, these are the days of Maggie mummies who want early diagnosis. So the days of conventional cultures, routine investigations are slowly getting replaced by more PCR-based, more molecular diagnostics. Quite a few labs are making their own concoction of tropical fever panel for PCR. Can you please comment? I would like Dr. Dhanlakshmi's view and
Yeah,
Dr.
it's not that
Tapisha's view.
validated, sir. Actually, so many panels are now coming up. But if you
Excellent.
see what are the panels available, every panel, see whatever disease we are not seeing. For example, in Chennai, all the panels will include malaria. We are not seeing malaria. So what is the point in getting that panel? So right now, there is no approved validated panel. As far as possible, try to avoid using this. And it's a combination of tests like urine routine, counts. I don't think, at different points of time, we order these kind of tests. So doing this is not going to help in clinical management.
Absolutely
Dr.
right, Dr. Dhanalakshmi. We are also not using the tropical fever panel because these are unvalidated panels. So those, especially those who are available in the market, in the private market. In Delhi, some of the large government hospitals have sourced these panels, and I don't know the source, and they are using it brilliantly. But in the private market, the tropical fever panels which are available are not validated, and they give inconsistent results. So we are not
Absolutely.
using them. bioMérieux is coming out with a tropical fever panel, which will be US FDA validated. And but I don't think it has, as you said, it has many India specific tests. I think it has chikungunya and probably dengue. Yeah, it
Which we
doesn't
are not
have.
Dr.
seeing nowadays.
Yeah,
Ma-
that's going to
Malaria and
More
lepto, I
clinical
think, are very
diagnosis and
recent
target
diseases.
the specific pathogen instead of searching in the dark.
Biofire is
Dr.
there.
Dr. Venkat
Yes,
Subramaniam, in your
yes.
practice, have you ever felt the need for doing molecular testing in a child with a respiratory tract illness? Do you ever order these respiratory panels, 5 panel, 6 panel? Have you
Yes.
felt the need? Do you find it useful?
Yes, actually, as per Dana Madam's statement, we need not test for in category A cases, but in moderate and severe cases, we may go for testing. But in pestering parents, affordable parents, and when a sick child getting admitted, I go for respiratory panel, RT-PCR, and sometimes to get know what is the prevalent virus in the community, I will be doing it free of cost. I will bear the expense for getting know what is the prevalent virus in the community. Even in yesterday, one boy was admitted for fever with absolutely no respiratory symptoms. Surprisingly, a few bit of cough only there, but he was found to have influenza A illness in RT-PCR only. So in some instances, RT-PCR is helpful in dealing with the respiratory cases.
Correct. So at least in Coimbatore, we are seeing lots of influenza H3N2 and respiratory syncytial virus cases. I'm sure Shivagasi and Tirunelveli, Delhi and Madras may also be following the same pattern.
Yes,
How
sir.
do you manage your children with moderate to severe bronchiolitis? Do you give them antivirals empirically? Do you test everybody for RSV? Do you believe in bronchodilators? How do you manage a moderately sick child with bronchiolitis?
Absolutely, no role of antiviral medications in case of RSV bronchiolitis. In fact, the hospital OP is flooded with bronchiolitis, and all the HFNCs are overworking. In bronchiolitis, in mild to moderate cases, only we go for saline 3% saline nebulization, and in the babies which are very sick with the evidence of impending respiratory failure or who not able to consume milk as well, we admit the child. We improve the hydration, and we are using along with 3% nebulization go for HFNC. HFNC is a very good blessing for treating bronchiolitis cases.
Sure. Dr. Raju, in your practice, when do you actually suspect complications of influenza, sir? Child starts off with a respiratory tract illness, influenza is positive, but day 3, day 4 of the illness, child continues to have high-grade fever. X-ray at admission shows a patch. We believe it is influenza pneumonia. At what point would you raise a red flag for a co-infection? If you suspect a co-infection, what antibiotic would you start, sir?
If a child continues to have high temperature and all admitted cases, probably they'll be subjected to the oral oseltamivir, because that is the only drug available, plus supportive measure. And of course, one initial shot of ceftriaxone we give pending the bacterial proof. And when the child continues to be sick, running high temperature even after 3 or 4 days of admission, think of secondary bacterial infection, and that has happened many times in the present epidemic. So in which case, probably the drug of choice we start would be the ceftriaxone in the correct dosage you have to start, and then continue along with that oseltamivir plus supportive measures.
At what point of time will you suspect a secondary infection, sir? How long do you think oseltamivir can be given a chance before we hit him with another antimicrobial?
Because textbooks say you can have prolonged infection even after 7 days of viral illness. ILI can extend even 7 days beyond, and child can be infectious. That's what the textbooks say. So if the child comes to you, say after 4 to 5 days, and then continues to have temperature, say more than 2-3 days, think of bacterial infection, prove the etiology, because I said a bedside CBC may be helpful in those situations.
Thank you, sir.
Aswath, in cases of unrelenting fever, in case of influenza, the possibilities are either pneumonia or developing complications like otitis media. Regarding pneumonia, since I am doing point of care ultrasound, it is very easy for me to rule out lobular pneumonia, parenchymal disease by way of doing ultrasound. In viral pneumonia, there will be minimal subpleural consolidation, only small bit of consolidation. But in bacterial pneumonia, lobar consolidation, there will be a telltale evidence of pneumonic changes that will help me to rule out and rule in pneumonia as well.
Sure. I think it's a brilliant tool to have. The point of care ultrasound has really made diagnosis of pneumonia at the bedside so important for a country like us. Tapisha, ma'am.
1 minute.
Sorry,
the present
sir.
H1N1 has a matchstick-like opacity in the right upper zone. Just start observing hereafter. That was told by my radiologist. They have a streaky opacity in the right upper lobe. Even without doing a microbiological evidence, you can say it's H1N.
It's a brilliant finding, sir. Thanks for sharing that, gem. Tapisha, ma'am, now that we have nirsevimab available in the country, even though it's at a prohibitive price, do you see that molecule taking off, ma'am? Because this season of RSV has been quite bad. Do you see there is a scope for vaccination against RSV for antenatal women? Do you see a role for nirsevimab for Aam Aadmi? Ma'am?
She has to unmute.
Tapisha, ma'am, are you with us? Ma'am, Dana ma'am, can I probably take the question if Tapisha ma'am is not able to respond?
Evidence looks promising, sir, but still we have not started using.
Neither, ma'am. Nirsevimab.
Yeah,
and you have not used.
Evidence
Ma'am,
looks
what about
promising.
in Delhi, ma'am? Ma'am has tuned out. Is she available?
She's still not logged out, I think.
Her name is not in the list, attendee list now.
Okay. So you see there is a potential, but there is still no.
I think in a couple of years we may start using.
Ma'am, we are coming to the end of the show, ma'am. I just want you again, because it's an antibiotic resistance awareness, we want you to tell us the starting pediatricians, youngsters, what can they actually do to avoid? What can we do to decrease the emergence of resistant bugs, ma'am?
Try to differentiate clinic.
Excuse me, Dr. Shivagurunathan, can you please mute yourself? Dr. Shivagurunathan, can you mute yourself, please? Dr. Shiva?
Try to make a clinical diagnosis, sir. So always try to differentiate viral versus bacterial. So if you write probable viral illness, then obviously you will not write antibiotic. Even if it is bacterial, try to think of what organism is causing that particular syndrome. If the children are stable, then target only the common organism and choose the right drug, right dose, and explain the parents how to give and complete the course of antibiotic. And if it
Dr.
is a
Raju?
hospitalized,
Yes.
Ma'am, sorry, ma'am. I thought you had
Yeah.
finished.
Hospitalized children always send blood culture before starting antibiotics. And start with your empiric choice should be like know your local antibiogram well. So what is happening? So for example, if you E. coli, how many percentage are ESBL producing? Then you'll be right in choosing your empiric choice of antibiotic. If at all you don't have a local antibiogram, then you can look into your ICMR data. Every year ICMR is releasing. They collect the samples all over India and they are releasing the antibiogram. So if you look at the antibiogram, then we may get a better idea which may be the ideal drug of choice. And these are some of the things we can do.
Dr. Raju, sir, what are the conditions where you will start antibiotic on day 1 without doing any testing, sir? You are absolutely sure of the diagnosis. No testing. I'm positive I will give an antibiotic on day 1. First visit to you, sir. Sir gives an antibiotic. What are those conditions, sir?
Suppose you see a very sick child getting admitted, definitely you take the samples and start them on in the initial
Sure, sir.
ceftriaxone, especially if the child is very young, less than say 3 months, or especially the newborns, should be given because the chance of bacteremia, if you delay, may be more, or the complications may be more.
In office practice, sir?
In hidden places like tonsillitis.
In office practice, sir?
Office mechanistic gas infections. If you
Stroke.
have a proven score of 4 to 5, even without investigations, I can start them on
Sure.
the appropriate
Dysentery
antibiotic.
also probably. Dr. Venkat?
In my office,
Your advice for budding pediatricians on how to curtail the use of antibiotics.
Definitely. In my office practice, to add on with the Raju says, UTI, skin infection, the hidden place, the tonsillitis, otitis media are the India conditions where I will start antibiotic on day 1 itself. And other than writing the diagnosis, viral LRTA, viral URTA, we dare to write for antibiotics. And other than that, now I am having the habit of putting one antibiotic chart in the last page of the file. Other than growth chart, vaccination chart, and the dietary guidelines chart, I have antibiotic chart in the last page in the file, wherein I need to write the diagnosis and what is the antibiotic I'm going to write and how many duration of antibiotic. That way I ensure that the entire antibiotic duration is completed. And for the past 1.5 years or so, I am doing this. And proudly, I can say that only on 3 to 4 cases only, there is a need for writing another second antibiotic course in the past 1.5 years or so. So we senior pediatricians, we should lead by example, because when the pediatrician is coming into practice in the initial period, they will be more hesitant. Instead of for fear of losing cases, they tend to write antibiotics. There is a period where I used to say, I have written antibiotic, so your child will be normal. Now I am in the level saying that, see, I am not writing antibiotic. Because your child is having only viral infection. That kind of confidence patient I need to give, then they're trusting and following my path. Many of the juniors here are not writing antibiotics now. So my suggestion is to go for antibiotic chart, to document every use of antibiotics in the file, so that we also dare to write the antibiotic again.
Yes, that's a beautiful piece of advice to give for the youngsters.
I also found in some records that they used to strike the previous prescription. They used to strike, so that patients should not go to the medical stores and then get the
repeat
antibiotic. Repeat it. So that is a good habit. Venkat is good. He is very academic.
Are we still missing Dr. Tapisha? I thought I can get some comments before we end today's program. Tapisha, ma'am? Dr. Venkat, can you see if she's still logged out?
Yes, yes. Already her connection is very poor right from beginning. She's not
Okay.
here. She's not here. Okay.
Sure. So I think over the past 1.5 hours, we've had some very, very useful insights and very practical deliberations on some important aspects of seasonal pediatric infectious diseases. Words cannot convey enough the thanks we extend to our panelists, Dr. Venkat, Dr. Raju sir, Dr. Tapisha, and Dr. Dhanlakshmi ma'am. Thanks for so patiently listening out to all our questions and being so very generous with your knowledge and delicious nuggets of wisdom that you were able to put up at various points. Thanks once again to IAP TNSC and thanks for making this evening a memorable one. I will wait for Dr. Rajendran, Dr. Thiru, Dr. Singarvelu sir, Dr. Srinivasan, Dr. Pandaraman to give their closing comments before we can say good night. Over to you, Thiru bro.
Thank you.
Ashwath, only two
Yeah.
comments from my side. Only two comments, particularly when the MAC score is indeterminate. When it is very low, no antibiotic. When it is high, it is antibiotic, no problem. It is indeterminate, delayed antibiotic therapy, that is after 48 hours, is the evidence-based recommendation from British people, NHS, as well as also it is very fine to be useful in practice. Number one, if our patients are very confident, definitely it works out thing. Number two, as you asked, in a resource poor setting where blood culture is a very remote possibility even for next 5 years. So the best option, particularly fever, when it goes beyond 5 days, and if you found it is a step-ladding pattern, rise of the fever and spleen is coming out, child is becoming toxic, you are justified in starting empirical anti-typhoid treatment. You are justified in empirical anti-typhoid treatment of Cefixime of 20 milligram per kg. You are justified. This is where we can, even without evidence, we can start empirical antibiotic therapy for typhoid fever. These are my two comments. Thank you.
Perfect.
Well, are you justified? That is a question.
Definitely, sir. Because in our place,
I
definitely
know. Cefixime is not an antipyretic. It is an antibiotic, you know.
No, sir. After concluding that we are treating as a typhoid fever. That is
Okay.
after 5 days, not on the first and second 2 days.
Right, pain, sir.
Right. Dr. Singarvelu sir, Dr. MSV, Dr. Rajendran sir, your concluding comments?
I just asked one question about this eosinopenia and enteric fever. I know that people say it's relatively specific for enteric fever. I just want to know, how do you interpret what happens to it when there is a underlying atopia and enteric fever is my question.
The enteric toxin is supposed to cause bone marrow suppression. That's what I learned. And also they cause vagal stimulation. That is the cause for bradycardia. And also there is one finding called the coating of the tongue, cecal gurgling. All these are being forgotten. The coating should be from this periphery to that periphery, not a simple coating. It should represent the lesions in the crypts of Leberker. That's what the thing we have inside. So that's what we were taught when we were undergraduates. Those clinical things are being forgotten. That Vishwanath said.
The other thing is regarding this paracetamol. I know that people talk about whether they want to use ibuprofen or mefenamic in addition to paracetamol. The one thing is, which I find, as an overdose when I see as a gastroenterologist, when they use the ibuprofen in addition to paracetamol, the patients do continue paracetamol. In addition to that, when they use ibugesic plus, for example, there's also paracetamol in it. This is an additional paracetamol on top of the regular paracetamol they're using. That one has to be careful. On top of that, most of these children might have cough, cold, etc. And some of these medicines, they have dextromethorphan, chlorpheniramine, and they also have paracetamol in that. And those things have to be looked at very carefully. And these are the combination paracetamol in those medicines, which actually, leads to the toxic dose. You have to be careful.
Thank you. Thank you for that insight, sir.
Ashwath, one last comment can I make?
Yes, please.
With respect to eosinopenia, the CBC is a very poor marker with respect to fever cases, number one. And if at all, particularly, there is a good study which found it's 70% of the persons with enteric fever have eosinopenia. And in our country, with a large amount of helminthic burden and everything, we can't be sure. But if it is there, it is a good surrogate marker. If there is leukopenia with eosinopenia on day 5 or day 6, It is a good surrogate marker, but it is not an absolute marker. Along with the clinical thing, it can be taken. Tapusha madam can comment on this because
Yeah,
she is
sorry,
the expert in entry fever. Okay.
Sorry, Dr. Ashwath, there was some problem. I quickly called my son, who's a troubleshooter, and he's fixed it. So
Sure,
I
ma'am.
missed some part of it. So
No,
I think you were
we
asking me about
actually,
nirsevimab.
yes,
I
we had
think
asked
that
about the scope for nirsevimab in Delhi, and because we came late to the show, I wanted your pieces of advice for practicing budding pediatricians on how to combat the menace of rising antimicrobial resistance. Your advice to young pediatricians.
I think we have already passed the ending time, so I'll be very short. One is that WHO has now taken out its position paper on nirsevimab in May this year, and WHO says that you give a shot to every infant, every baby who is born. And also recently, I think the price has come down. Am I right, Dr. Dhanlakshmi? They have revised the price. It has come down. And we've been advising to all our NICU graduates
NICU
at least,
graduates.
but none of them has agreed. So the price is
Coming on
prohibitive.
top of the NSU
Yeah.
bill, I think nirsevimab is
Yeah.
the final kick in the butt.
Absolutely.
The cost
So
is
it
less,
has not
probably more
really
takers.
worked. Yes. But WHO has advised in the position to, so maybe the costs will come down. That's one thing. The second thing is eosinopenia is definitely not specific for enteric fever. Many bacterial infections, you will see eosinopenia. It's when you combine it with other things, for example, a normal count, neutrophilic count, raised SGPT, then you also have eosinopenia, CRP, which is borderline raised or raised. That is when it comes in, it has some clinical relevance. If these things are not there and only eosinopenia is there, it doesn't really mean anything. So don't give too much importance to it. But yes, child with 4-5 days of fever, nothing else. TLC about 5,000-6,000, N60, L30, E0, something like that, with a CRP of 40-50, SGPT around 70. It's a very good, indicator. And I think you said how to prevent AMR. I think we are all experts in that. When we write a prescription on the paper with our pens, we have to stop and think. And we have to decide whether we are doing justice to ourselves and to the society and to the patient to whom we are writing this. I think that's all we need to tell and percolate. And I think this TN chapter is doing a great job. I've listened to so many other programs, etc. But this idea that you've got everyone together and everyone is discussing and doing troubleshooting and asking questions, this must be the first such, because usually 2 or 3 people speak and everyone else listens. So this is very interactive, and hats off to all of you. Thank you so much for having me. Thank you.
Thanks for your time, ma'am. Thanks for your pearls of wisdom. We are indebted, ma'am. If there are no further comments, can we say good night and call it a well-spent evening? Dr. Shingarvelu sir, Dr. Rajendran, Dr.
Can we
Thiru.
just ask for a closing comments from our immediate past president, sir, Dr. Balashankar, sir, who is also.
Very good evening. Ellarkum good evening, Pa.
Oh, sorry,
Thank
I
you.
missed, sir.
Thanks,
Sorry, sir.
Thanks for calling me. Actually, I appreciate Venkat that he is one of the leading persons in his area, because students learn from students or anybody, junior colleagues learn from what we do than what we teach. That is what I honestly believe. In the medical college also, they will look at what we are doing and they take what. Even what I say is the antibiotic stewardship starts from doing the investigations itself. There should be investigatory stewardship. Don't do investigation unnecessarily. I will ask the PGs to do the investigation only when it is necessary. Otherwise, you will get some result and you will be giving some drug which is absolutely unnecessary. So, investigation stewardship should be there. That's what I say. If this result, when you see the result, if it is going to alter your treatment in any way, then only you do that investigation. Otherwise, you don't do it. So, in that way also, you can reduce the antibiotic use. Okay, then
Yes,
coming to this enteric fever, what Dr. Palaniraman told is absolutely right. Fifth, sixth day of fever, having a spleen of 2 liver of 2 centimeters, spleen just palpable, coated tongue, sick looking child. We are absolutely justified in starting in the periphery. Even Madurai, the culture facilities are not that good. It is there. One centers are good, but it's not that good. So we may have to, even though we send blood culture, half of them come as positive, half of them come as negative. And some or other, now people are not at all advising Vidal. Maybe the only use of Vidal is we can have a supportive evidence for us to say that, yes, we have treated it, yes, centric fever, because this result has come as positive. And one thing I can say, even if you start the child empirically on cefixime, within a day or two, if the fever comes down, it's unlikely to be enteric fever and we can stop in cefixime. Because enteric fever does not come within 1 or 2 days of starting cefixime. Maybe it's a prolonged viral fever or something which is subsided by day 6 or day 7. So if it comes down on day 6, within 1 or 2 days of starting cefixime, I stop cefixime. That's what I do. Thank you for the opportunity.
Lovely, sir. Thank you, sir.
Thank you, sir. I think we can close today's session. Thank you very much for participation from all the panelists and Dr. Ashwath for a wonderful, very enlightening session. I think we are still going to have one more before the end of the year. We'll have another very useful session. Thank you very much and good night.
Good night, one.